Hello, my name is Cafrey and I'll be talking about Breo Ellipta inhaler. I want to go over how to properly use the inhaler following the diagram. First, check the dose counter. Do not shake at any time. Slide the cover down until a click is heard. Breathe out gently away from the inhaler. Put the mouthpiece in the mouth and close lips to form a good seal, but do not block air vent with fingers. Breathe in steadily and deeply. Hold breath for 5 seconds or as long as comfortable. While holding breath, remove the inhaler from the mouth and breathe out gently away from the inhaler. Afterwards, slide the cover upward as far as it will go to cover the mouthpiece. I'm going to go over the patient consultation points. Side effects may include nasopharyngitis, cough, bronchitis, sinusitis, oropharyngeal pain, dysphonia. We want to advise patients that drugs is not used for acute symptoms of COPD or asthma, and we need to advise patients to rinse mouth afterwards to reduce the risk of oropharyngeal candidiasis. We instruct patients do not to exceed maximum recommended dose of 1 inhalation per day, and lastly, warn patient to report any symptoms of infection, hypocorticism, or adrenal suppression. Some introduction about Breo and Ellipta. So Breo and Ellipta was FDA approved on 2013 as a maintenance inhaler for COPD patient and developed by GSK, which is GlaxoSmithKline. The generic formulation of fluconazole and Breo is manufactured by Prasco and released on June of 2022. GSK brought in a revenue of almost 1.2 million pounds, which is equivalent about 1.38 billions of dollars in year of 2022. Out of all those sales, the U.S. sales were about 498 million pounds, which is equivalent almost 599 millions of dollars in the year of 2022. So the mechanism of action. So the fluconazole aspect is a synthetic trifluorinated corticosteroid with a powerful anti-inflammatory effects. His mechanism of action in treating COPD is unknown, but the corticosteroid have a wide range of action on multiple cell types, which includes mast cell, eosinophil, neutrophils, macrophage, and lymphocytes, and mediators like histamine, eicosanoids, leukotriene, cytokines involved in inflammation. The second aspect, which is the Breo, which is a long-acting beta-2 adrenergic agonist, which increases the AMP levels, which result in the relaxation of bronchial smooth muscle and inhibition of the release of mediators of instantaneous hypersensitivity from mast cells. So the Ellipta has two indications, which is the chronic obstructive pulmonary disease, also known as COPD, and asthma. Dosages. For chronic obstructive pulmonary disease, the instruction is 1 oral inhalation of Breo Ellipta of 100 microgram over 25 microgram once daily. For asthma, there's two different dosage strengths. The instruction is 1 oral inhalation of either Breo Ellipta of 100 microgram over 25 microgram or 200 micrograms over 25 microgram once daily. Contraindication. So there's two contraindications that we should be focusing on. The first one is primary treatment of status asthmaticus or other acute episodes of COPD or asthma where intensive measures are required. The second one is severe hypersensitivity to milk proteins or demonstrated hypersensitivity to fluconazole, albuterol, or any other excipients. There are 5 adverse events that we should be looking for. First one is the fungal infection of Candida albicans infection. Second is the increase of risk of pneumonia in COPD. Third one is immunosuppression. Fourth one is hypercorticism or adrenal suppression. And last but not least, reduction in bone mineral density. I want to go over the warnings of asthma-related death. There's 2 points that we wanted to focus on. The first one is long-acting beta-2 adrenergic agonists or LABA, such as Breo, can increase the risk of asthma-related death. There's a placebo-controlled trial with another LABA or somaterol showing an increase of asthma-related death. This finding with somaterol is considered a class effect of all LABA. Currently available data are inadequate to determine whether concurrent use of inhaler corticosteroid or other long-term asthma control can mitigate the risk of asthma-related death from LABA. Now, the second point is when treating patients with asthma, only prescribe Breo Ellipta. For patients not adequately controlled on a long-term asthma control medication, such as inhaled corticosteroids, or whose disease severity clearly warrants initiation of treatment with both a ICS or a LABA. Once asthma control is achieved and maintained, assess the patient at regular intervals and step down therapy. For example, of discontinuing Breo Ellipta if possible without loss of asthma control, and maintain the patient on a long-term asthma control medication such as inhaled corticosteroids. Do not use Breo Ellipta for patients whose asthma is adequately controlled on low to medium dose of inhaled corticosteroids. Last but not least, drug interaction. Inhibitors of CYP450 and 3A4. So these should be used cautiously when considering the co-administration of Breo Ellipta with long-term of ketoconazole and other known strong CYP3A4 inhibitors, monoamine oxidase inhibitor, and tricyclic antidepressant. So this second point, like Bureterol, like other beta-2 agonists, should be administered with extreme caution to patient being treated with monoamine oxidase inhibitor, tricyclic antidepressant, or drugs known to prolong QT intervals, or within 2 weeks of discontinuation of such agents. Third point would be the beta-adrenergic receptor blocking agents. So beta blocker not only blocks the pulmonary effects of beta agonists such as Bureterol, but may also produce severe bronchospasm in patients with COPD or asthma. Therefore, patients with COPD or asthma should not normally be treated with beta blockers. Last but not least, non-potassium sparing diuretics. The ECG changes and or hyperkalemia that may result from the administration of non-potassium sparing diuretics, such as loop or diazide diuretics, can acutely worsen by beta agonists, especially if the recommended dose of beta agonist is exceeded.